Before viewing this month's online CPD, please make sure you answer the pretest. This is to assess if there is enhancement of your individual continuing professional development. Hi, I'm Dr. Alma Bella Carrascoso Cuartero, member of Philippine Pediatric Society, Southern Tagalog Chapter, and a pediatric cardiologist. Welcome to Fixing a Broken Heart, Approach and Management of Rheumatic Fever and Rheumatic Heart Diseases, Realities and Strategies. The objectives of this lecture is to emphasize the burden and realities of rheumatic fever and rheumatic heart diseases, to discuss the pathophysiology of rheumatic fever and rheumatic heart diseases, and to explain the approach to diagnosis and strategies in the management of RF-RHD. The global burden of RF-RHD is about 2.4 million, 500,000 new cases yearly, 300,000 of which who acquired rheumatic fever yearly develop rheumatic heart diseases, and it affects 5 to 14 years of age of children and adolescents living in developing countries. Mortality is 233,000 annually. The prevalence rate of rheumatic fever, rheumatic heart diseases cases is seen in this map, showing that developed countries has already very low prevalence rate of 0.3 in comparison with the different developing countries, which ranges from 0.8 to 5.7 cases per 1,000 live births. However, the reality is that the true prevalence rate of rheumatic fever and rheumatic heart diseases is actually higher than those reported. In the March 10, 2012 published studies done by the different developing countries, it shows that the echocardiography-based screening, which is seen in the yellow bar, is higher in comparison with screening using only clinical physical exam as basis for screening. It is shown by the blue column. Hence, RF and RHD remains a major public health problem in developing countries, including the Philippines. The true prevalence rate of RF-RHD is difficult to estimate because of scarcity of comprehensive disease registries, especially in the Philippines. We also use passive survey systems and underreporting of cases. Realities is due to socioeconomic and health services factors wherein poverty, overcrowding result in rapid spread of streptococcal pharyngitis, leading to higher incidence of strep pharyngitis and higher incidence of rheumatic fever and recurrence attacks. Inadequate diagnosis due to shortage of expert frontliners result to higher incidence also of rheumatic fever and recurrences. Misdiagnosis or late diagnosis of rheumatic fever cause in an unawareness of the patients of the first episodes of rheumatic fever and lead to more severe progressions of the disease. Inadequate and non-compliance with secondary prophylaxis due to low level of awareness and understanding of the disease in the community leads to higher rates of rheumatic heart disease, repeated hospitalizations, and expensive surgery. Acute rheumatic fever is an autoimmune inflammatory disease caused by group A beta hemolytic strep that targets specifically the heart, the joints, the brain, and the skin. Despite the dramatic nature of the acute episodes, rheumatic fever leaves no permanent damage to the brain, the joints, or the skin. However, it causes persisting heart damage called rheumatic heart disease. 0.3% of cases of beta hemolytic strep pharyngitis, even though treated, can also develop rheumatic fever in genetically susceptible hosts. Rheumatic heart disease is the most serious complication of rheumatic fever. Recurrences of rheumatic fever cause further valve damage, leading to worsening of rheumatic heart disease. The actual pathogenesis of rheumatic fever and rheumatic heart disease is still unknown. However, several studies have shown that it is due to delayed non-suppurative sequela of pharyngeal infections with group A streptococcus, and it has a latent period of 2 to 3 weeks before the onset of rheumatic fever. Large number of different serotypes of rheumatogenic strains of streptococcal pharyngitis are identified in these studies. Molecular mimicry is also mentioned, wherein antibody produced by body against strep M protein antigen cross-react with the normal host tissue. And this usually occur in genetically susceptible hosts. This is a complex maze of events about the pathogenesis and pathophysiology of rheumatic heart disease. Note that the rheumatic fever and rheumatic heart diseases started with a simple innocuous streptococcal pharyngitis that, if left untreated or undiagnosed, cause rheumatic fever, and if the rheumatic fever is halfly treated or progresses and develop recurrences, will end to developing rheumatic heart disease because of fibrotic connective tissue changes in the valves, leading to progressive fibrous thickening, leading to pancarditis and subsequent sequela of congestive heart failure of rheumatic heart diseases. This, as we can see in this map, it started as a simple streptococcal pharyngitis. However, if not treated, it extracts a very high cost in the host. This is a summary of the pathway of rheumatic fever, rheumatic heart disease infection. It starts as group A strep infection, then leads to rheumatic fever, then to recurrences of rheumatic fever ending in rheumatic heart diseases and its complications. The management of rheumatic fever and rheumatic heart disease depends on the stage wherein you see the patient. If you see the patient with streptococcal pharyngitis, then the management is primary prevention. If this develops in a genetically susceptible host into rheumatic fever, then you use secondary prophylaxis. If it develops into rheumatic heart disease, then you use tertiary preventive management. The different prevention strategies is the most appealing option in developing countries because of finances. If we deal with the determinant causes, which are the socioeconomic factors of rheumatic fever, then the point of management is called primordial prevention strategy, with the goal of eliminating the risk factors at the earliest stage. This is a very difficult prevention strategy because it entails large amount of finances. If we deal with the group A strep pharyngitis, we use primary prevention strategy with the aim of preventing the development of the first episodes of rheumatic fever. In treating rheumatic fever, we use secondary prevention strategy, or what is well known as secondary prophylaxis, which with the aim of preventing development of rheumatic heart disease and rheumatic fever recurrences. If the patient developed already rheumatic heart disease, then we use tertiary prevention strategy, meaning reducing the symptoms and disability of the patient and preventing premature mortality. In primary prevention, the different strategic steps are prompt correct diagnosis of group A beta hemolytic strep pharyngitis to identify individuals who are most high risk of developing rheumatic fever. Step 2 is prompt treatment once you are sure the patient has a strep pharyngitis, and because studies have shown that treating rheumatic fever within 9 days of symptoms will prevent development of rheumatic fever. In this study, we eradicate the microorganism, which is the primary prevention goal. We prevent development of future gas infections to prevent recurrence of rheumatic fever. This is called the secondary prevention. And symptomatic relief of acute disease manifestation. This is the tertiary treatment of strep pharyngitis. In the prompt correct diagnosis of strep pharyngitis, it entails using epidemiologic features of the disease, which is 5 to 15 years of age, recent close contact with documented case, and known high prevalence of strep infection in the community. Likewise, you should use clinical feature suggestive of strep infection in comparing it with the most common cause of pharyngitis, which is viral pharyngitis. Strep pharyngitis has beefy red swollen tonsillopharynx, high fever, sudden onset of sore throat, tender and large anterior cervical nodes, and tonsillopharyngeal exudates. In comparison with viral pharyngitis, there is history of cough, coryza, conjunctivitis, and characteristic enanthems or exanthems. If you are having a hard time diagnosing strep pharyngitis clinically, then you can use this algorithm to tell you whether you should do throat culture or whether you should start antibiotic immediately. By assessing the risk factors for gas pharyngitis like 5 to 15 years of age, living in lower socioeconomic community, and past history of rheumatic fever, if the patient has 2 to 3 of these risk factors, then you use these clinical criteria and note its absence or presence. If there is any of these clinical criteria with the 2 to 3 risk factors, the patient is high risk. Then you should do throat culture and start antibiotics immediately and empirically. If the patient has 2 to 3 risk factors but has none of the clinical criteria, then the patient is medium risk. You also do throat culture but start antibiotics only if gas positive. If the patient has none of the risk factor or only one risk factor, then use a scoring system. Use this clinic score 1 point each in these different clinical criteria. If the patient score 4 to 5, then the patient is high risk. Do throat culture and start antibiotics immediately. If the score is 2 to 3, patient is medium risk. Do throat culture but start antibiotics only if gas positive. If the score is 0 to 1, the patient is low risk. There is no need to do throat culture, no need to start antibiotics, but treat the patient symptomatically. The bottom line is a single element in the history or physical exam is not enough to confirm probability of strep throat. Hence, physicians should adopt a set of clinical prediction to determine whether rapid antigen test or culture is warranted to diagnose strep throat. In the early management of strep pharyngitis, we should start the treatment promptly within 9 days to prevent rheumatic fever. The following are the different antibiotic regimen that can be used for primary prevention of rheumatic fever, like benzathine penicillin, phenoxymethylpenicillin, amoxicillin, and if allergic to penicillin, you can use cephalosporin, clindamycin, azithromycin, and clarithromycin. Failure to identify patient with strep pharyngitis will lead to acute rheumatic fever in genetically susceptible hosts. There are times when it's very difficult to extract history of rheumatic fever because 10 to 30% of the patient do not recall preceding sore throat. This is due to existence of asymptomatic throat infection complicated by an inflammatory response. And this is also due to lack of expert frontliners and lack of awareness of the disease. Family factors like attitude, considering sore throat as not important, and using traditional remedies are also causes of rheumatic fever. Patient factors like having high threshold for pain and tolerance and wrong priorities are also causes. 0.3% of those treated will still develop rheumatic fever in genetically susceptible patients. 3% of those who are not treated will develop rheumatic fever, and 60% of rheumatic heart disease patients who develop strep tonsillitis will develop subsequent rheumatic fever. The challenge now is to do an accurate diagnosis of rheumatic fever once you suspect this disease. Accurate diagnosis of rheumatic fever is important because overdiagnosis will result in individual receiving treatment unnecessarily. Underdiagnosis may lead to further episodes of rheumatic fever causing cardiac damage and the need for heart valve surgery, which is very expensive, or premature mortality. Currently, there is no diagnostic laboratory test for rheumatic fever. Diagnosis remains a clinical decision based on identifications of the major and minor manifestations of the illness. This is what we call the Jones criteria. Remember that Jones criteria is used only to establish initial attack of rheumatic fever. It is not intended for rheumatic activity determinations or chronicity of rheumatic heart disease. If you want to know or monitor resolutions of inflammations or detect relapses, then you use the CRP and ESR determination, which has high sensitivity but low specificity. The Jones criteria is not to predict course or severity of rheumatic heart diseases. In the latest revisions of Jones criteria, which is published in 2015, those patients' populations with evidence of preceding gas infections, the initial ARF diagnosis needs 2 major manifestations or 1 major plus 2 minor manifestations. Likewise, recurrences of rheumatic fever also need 2 major or 1 major and 2 minor or 3 minor manifestations. In the latest revisions of Jones criteria, the American Heart Association divide the patient population into low-risk population using polyarthritis as major criteria in the low-risk population, and in the moderate and high-risk population, monoarthritis is added as major criteria Likewise, polyarthralgia is also added as major criteria. The inclusions of polyarthralgia or monoarthritis as major manifestation, remember that it is only applicable for moderate or high-risk populations. Only after careful consideration and exclusion of other causes of arthralgia such as autoimmune, viral, or reactive arthropathies. These are the differential diagnoses that you should consider for arthritis, and the differentials for carditis, and the differential diagnosis for chorea. The presence of rheumatic chorea alone or the presence of rheumatic carditis alone is already sufficient to diagnose rheumatic fever. You don't need to have the other manifestations in the Jones criteria, or you also do not need evidences of previous strep pharyngitis infection. Likewise, patients who are presenting for the first time with a diagnosis of pure mitral stenosis or mixed lesions does not also need the other criteria in the Jones criteria. We know that rheumatic fever is a pancarditis, meaning that it affects the endocardium, the myocardium, and the pericardium. Hence, it is very important to differentiate rheumatic carditis from other common causes of endocarditis, myocarditis, and pericarditis. Very important differential diagnosis for rheumatic carditis is infective endocarditis, especially on top of an existing rheumatic heart disease, because infective endocarditis can also produce joint symptoms, murmurs, high fever, and also increase acute phase reactance. Initiating steroids in a patient with infective endocarditis on a mistaken diagnosis of rheumatic fever can be catastrophic. There is what we call subclinical rheumatic carditis, meaning there is carditis in the patient, but it lacks auscultatory findings that will tell you that the patient has carditis. Echocardiography has objective signs that can tell us presence or absence of rheumatic carditis. A regurgitant jet of more than 1 cm in length, a regurgitant jet in at least 2 planes, a mosaic color jet with a peak velocity of more than 2.5 meter per second, and a jet persistent throughout the systole in the case of mitral valve disease and throughout diastole in aortic valve disease. Elongation of the anterior mitral chordae indicating that the valve might have been damaged. Patients with subclinical valvular regurgitations may develop an audible murmur in 2 weeks, or they may continue without audible murmur for the next 18 months to 5 years. Hence, it can progress to irreversible sequelae such as mitral stenosis if left undiagnosed. The recommendations of the American Heart Association with regards to the latest revisions of Jones criteria, published 2015, recommend echocardiography with Doppler in all confirmed or suspected rheumatic fever. Echocardiography should also be done in patient who has no auscultatory findings to diagnose subclinical carditis. And echocardiography that are not consistent with carditis should exclude rheumatic diagnosis in patients with murmur otherwise thought to indicate rheumatic carditis. The minor criteria in the Jones criteria are also divided into low-risk populations and moderate to high-risk population. As you can see, in the low-risk population, polyarthralgia is a major criteria. However, monoarthralgia is already added as a minor criteria in moderate to high-risk population. And a level of 30 mm ESR is already enough to consider as one of the minor criteria in moderate and high-risk population, in contrast with 60 mm ESR in low-risk population. Acute rheumatic fever's major priority is confirmations of diagnosis. With the exceptions of heart failure management, none of the treatments of rheumatic fever has been proven to alter the outcome of the acute rheumatic fever episodes or the amount of the damage already present to the heart valves. Hence, there is no urgency to begin definitive treatment unless you are sure that the patients have rheumatic fever. Starting non-steroidal anti-inflammatory drugs reduce the symptomatology of the patients and further confuse the diagnosis. Anti-inflammatory drugs like aspirin in patients with arthritis with or without myocarditis can be used in a dose of 75 to 100 mg per kilo per day for 6 weeks, and tapering the dose once symptoms resolve. Another regimen for anti-inflammatory drugs is that you can start with a lower dose of 50 to 60 mg per kilo per day for a total of 12 weeks. For those non-responder to aspirin in 4 days, you have to rule out conditions like chronic inflammatory or myeloproliferative disorders before switching to steroids. Once the patient has moderate to severe carditis, you can already start the patient with steroids using prednisone at the dose of 2 mg per kilogram per day with a maximum of 80 mg per day, and then tapering it over 2 to 4 weeks and starting aspirin during the tapering period. For those who are non-responders, then you give methylprednisolone 30 mg per kilo per day. This is a summary of what we have mentioned about anti-inflammatory therapy. Supportive medical therapy in the form of bed rest and indoor ambulation will be determined by the presence or absence of carditis, cardiomegaly, or congestive heart failure. The bed rest and indoor activity indoor activity ranges from 2 weeks to as long as 3 months. Those patients who has chorea, you can use haloperidol at a dose of 5 mg per day and gradually increasing it depending on the response of the patient. There are useful signs that can help you identify patients with chorea. The milkmaid's grip, which is a rhythmic squeezing when the patient grabs your finger. Spooning, which is flexion of the wrist and extension of the fingers when the hands are extended. Pronating, which is turning outwards of the arms and palms when held above the head, and inability of the patient to maintain tongue protrusion. Strategy 3 is secondary prevention, or what we call secondary prophylaxis, that is to prevent development of rheumatic heart disease or prevent recurrences of rheumatic fever. The goal of secondary prevention, which is to prevent recurrent rheumatic fever and worsening rheumatic heart diseases, we can use benzathine penicillin 1.2 million units every 3 weeks in high-risk patients, or oral penicillin, macrolide, and in high-risk situation, you should use them every 3 weeks. Adherence of secondary prophylaxis is improved when patients feel a sense of personalized care and belonging to the clinic, and when the recall systems extend beyond the boundaries of the community. There are different strategies that can improve adherence for secondary prevention. That is, you improve delivery and patient care, give family educations, emphasizing the reason, the consequences of giving secondary prophylaxis. And coordination with the other health services. Measures to reduce benzathine injection pain can be done by using Gates 19 needle, delivering the injection slowly, allowing the alcohol to dry before injecting, applying pressure with the thumb for 10 seconds before inserting the needle, and distracting patient during injection with conversation. Identify local dedicated staff to deliver the secondary prophylaxis and coordinate routine care. Establish centralized coordinator and registry to assist in monitoring of compliance. Promote the importance of secondary prophylaxis in preventing recurrences of rheumatic fever and rheumatic heart disease. Evaluate local health services to identify specific barriers to injections. Duration should be 10 years or until 40 years if the patient has persistent valvular disease. However, if the patient has no residual heart disease, you can give it for 10 years or until 21 years of age. If the patient has no carditis, you can give it for 5 years or until 21 years of age. We should never continue benzathine penicillin before 21 years of age because recurrences are still common. If the patient has mild to moderate rheumatic heart disease, never discontinue it before 35 years of age. However, if the patient has severe rheumatic heart disease, you should give it for lifetime. Strategy 4 is tertiary prevention. This is applied in patients who has already rheumatic heart disease. Failure to prevent rheumatic fever leads to recurrences of rheumatic fever, rheumatic carditis, progressive valvulitis, scar formations, valvular damage, resulting in chronic rheumatic heart disease. 50% of them are mitral valve disease, 40% are combinations of mitral and aortic valve, and 3% are aortic valve alone. Be mindful that acute aortic regurgitation is a condition wherein there is no time for ventricle to compensate, leading to cardiogenic shock, and usually because of the low cardiac output, the normal compensatory mechanism of the heart is to increase heart rate. Hence, we should not give treatment to lower the heart rate because it can worsen the hemodynamics of the patient. Be mindful also that acute mitral regurgitation can cause acute pulmonary edema and result in low cardiac output, precipitating cardiogenic shock. And in this time, the patient ventricle has no time to compensate. And echocardiography is very important for the diagnosis of acute mitral and acute aortic regurgitation. In summary, our greatest challenges often are our greatest opportunities. There is a need for better quality data, comprehensive and coordinated rheumatic heart disease control programs, echocardiography-based screening, and commitment in implementing a comprehensive public health strategy. I will end this lecture by saying that throughout the colorful and vibrant life of children, rheumatic heart disease patients live with a spine-chilling fear of the doom of death, which at any moment can fall on their life. When their peers are able to run and climb, rheumatic heart disease patients may be panting for breath after the slightest exertions for routine activities. When their friends are eligible for study, they are denied of such opportunities and chances because of the presence of rheumatic heart disease. Thank you. Please answer the post-test. All for the Filipino child.